Hello, California Neurodiagnostic Society. I'm Michael Talcott. You have Shannon York here, that is our local vascular specialist and neuro TCD expert. And then you have Patrick Chamberlain, who is your local representative on the West Coast. And we are here to help educate you a little bit on TCD and how everything's going in the TCD world. Welcome aboard. Thank you, Shannon, for being here. Thank you, Patrick.
You're welcome. Excited to participate.
Yeah, me too. I didn't know. Did you have a few initial questions or any topics you wanted me to address?
Yeah, I would, Shannon. One of the questions I wanted to ask you is, how long have you been doing TCD and some of the facilities that you've worked at, and what you find is interesting in your current path?
I've been doing, well, I'm Shannon York, just as Michael said. I originally hail from South Carolina, and I live now in Colorado. And I graduated from ultrasound school in 2008 and started doing transcranial Doppler, I think in 2009. At the facility that I worked at, it was one of the only, at the time, hospitals in South Carolina that were performing transcranial Doppler. And it's not something that you dive very deeply into during your training initially, which I think is unfortunate. I'd like to see that change. But, I'd watch the other sonographers go up, spend a couple hours in the different units doing the transcranial Doppler and come down and communicate with the physicians. And I would see, kind of as I was observing, would see the physicians acting on the information that they were given from the text kind of in live time. So I basically insisted on being trained in transcranial Doppler because I wanted that next level of ultrasound. I felt like, number one, it and we'll kind of describe this in a minute, it keeps you on your feet. You're definitely using your mind while you're doing it. You're using your problem solving skills, and it's a very interesting ultrasound. And you're always doing this with different ultrasound modalities, but you're really playing a direct role in patient care, and a couple of different facets. There's different applications of it. So I asked to be trained, and I've been very passionate about it ever since.
Thank you. And for me, I've been doing TCD off and on for 30 years. And the thing that really hits me compared to other things is the direct, quick impact that we can make by a quick diagnosis. We can assess why the patient's having the problem quite frequently, and we can tell whether it's possibly heart or whether it's actually coming intracranially. And the impact in the quickness that we can do this is amazing.
I think so. And it has really enriched my career. Doing the same thing over and over every day. When I tell people that I do ultrasounds, they automatically think scanning babies. That's what's most commonly known, and there's so much more out there. But adding this modality in and all of the different applications within it has really kept it interesting for me. I'm using a different kind of part of my own brain while I'm doing the ultrasound, because we're not necessarily focused on imaging, but focused on analysis of blood flow. So it's using different principles. And that can be taught to other individuals within healthcare that are not actually sonographers. So that's why I'm excited to talk about it today, to see if we can open some doors for some other individuals.
Thank you so much. And Patrick, I know on the West Coast, you've really hit the ground running with a lot of major institutions, from all the way down to San Diego, all the way up to Washington. Can you tell us what really makes you so enthusiastic and such a driver on the West Coast in your mission on that West Coast to educate?
Well, kind of like Shannon, I've been involved in on the vascular side of ultrasound for a long time, but only recently got involved with TCD. So it's new and it's exciting for me. I started in 2018 learning about it and got educated at places like Swedish Neurovascular Institute and Cedars-Sinai. But the interesting thing that I've noticed on the West Coast that maybe differs a little bit from back east is there are a lot of TCD houses out here that are neuromonitoring based. So they're not being run out of the vascular lab and they're not being run out of radiology or cardiology. They're being run out of the lab of the folks that are attending this presentation.
Yes, I see the same thing. I'm in Michigan, and what I notice a lot is the neurodiagnostic lab is doing TCD testing frequently, but I'm seeing it not utilized as much as it is on the West Coast. That's one of the benefits I have since I help people on the East, West, all over, is I get to see all different aspects of it. And I love the West Coast and how you're using it on the West Coast as it should be used. A wide variety of diagnostic procedures are being done with it. You aren't just doing testing just for TBI, you're doing testing for a wide variety of tests with the TCD.
Sorry,
so, Shannon,
not mean to advance to the next. Sorry.
Shannon, can you go ahead and go right on through your presentation and introduce the folks to TCD?
Absolutely. I did not mean to hit a button and advance to the next slide. I apologize. So I'm glad that we're doing an interactive talk, because I think we all have something to add. So I kind of reviewed the slideshow with you guys, and at any point, if you have anything to interject or ask, please stop, and I'll kind of talk on the PowerPoint and off the PowerPoint. It's just kind of good to have those visuals in the background. So the first thing I wanted to do was just review a few basic principles. So anybody that's, thinking about getting involved in TCD would just have an idea of what the basic knowledge frame is. I'm going to keep it pretty light and not get very technical. That's what we would do when we actually get into the training aspect of TCD. So this is just going to be an overall kind of show of TCD and what all is available through the applications. So you do not need to be a sonographer, just to point that out again, to enter into doing transcranial Doppler. We're actually going to talk a little bit more about different avenues that other healthcare professionals can use to enter into doing TCDs. But you would need just a basic knowledge of ultrasound as it pertains to transcranial Doppler and gathering the data through the ultrasound system. Again, that can be taught without getting hugely in depth to all the different ultrasound physics and procedures and imaging. So just a basic knowledge. There are a few mathematical and physical principles involved with TCD that are very unique to TCD. And again, I'm just going to reference blood flow analysis. So that can be learned pretty readily and easily with, kind of using the hands-on, some study material. We would need a basic memorization of the cerebral vascular anatomy. So basically kind of just memorizing the circle of Willis. And that comes into play. Not only do we need to know what we're insonating when we're doing the TCD, but we'll always need to keep a picture of the circle of Willis kind of hidden in the background of our thoughts when we're doing the TCD. I'll have a picture that can kind of show that a little bit better, because we're going to be using blind Doppler to do these procedures. And then just in a basic awareness of pathologies that we can observe with TCD, the applications. So I've actually prepared a section at the end where I'm going to highlight some of those, and we'll kind of show you on the actual system or a TCD system how we would work through obtaining information for each one of those applications. I like to show this picture just to kind of make it start to make sense. Usually the first thing I tell people to imagine is if they, and by the way, this is a picture of the Circle of Willis, and this is a report taken from the Dolphin TCD system. The kids' workbook game when you were little of connect the dots, and our basic goal when we're doing a transcranial Doppler is to use the ultrasound to plot by depth, different depths along each vessel. So we put a little dot here, we put a dot here, and we put a dot here, and we put a dot here. And when we connect them all together, voila, we have the Circle of Willis. So we can use each person's exam compared to their, same exam. If, let's say, for instance, we had, can you see my pointer, by the way?
Yes, we can.
Okay.
Yep.
If we had a velocity or a speed here of the blood flow documented, and then we moved to this point and this point, and all of a sudden we had a major jump here, we could identify that there is a possible narrowing in the vessel here. So it's very meticulous. We're going to use the pulse wave Doppler to map through and allow the physician to see and compare velocities from one section to the next. This can also be done with certain applications where we would map the person's velocities on day one, and then we could compare them a day later, a couple days later, to see if the velocity changed at that particular spot. So that'll make more sense as we talk about some of the applications, but this is basically the overall goal of what we're doing during a TCD examination.
And Shannon, can you go back to that last slide real quick?
Sure.
Can you please describe the 4 vessels that are delivering blood to the circle?
Yes, and I can pull up a better picture of that possibly in a minute.
Okay.
And you're referring mainly to the internal carotid and the
the verts.
Well, these would be the source arteries down here. I always, when I look at this, it looks like a little man to me. His little feet, these are his arms. The vertebrals back here deliver blood flow basically up the back of the neck and deliver to the posterior circulation back here. And then we would have another vessel coming kind of at an angle coming towards us, the internal carotid artery. We'd have bilateral, so there'd be an internal carotid here, and that would supply the anterior circulation. So we have to know about those source arteries. Of course, if there's any kind of major problem in those source arteries, it would affect the overall perfusion. It's, we call it the Circle of Willis, and it's a beautiful thing, I think, the word circle, because basically we were made to compensate or collateralize in the event that there is a problem with one of those major source arteries. So we could effectively have a disease here, and the circle allows perfusion to kind of keep it coming from either the front or the back to the front, or the left side or the right side to the opposite side. So it's not a circle by happenstance. And I have a couple more pictures of the Circle of Willis and kind of the source arteries, I think, in just a minute.
Very good.
This just gives a brief, very good, simple pictorial of what we're attempting to do. Again, with the transcranial Doppler, we'd have, the arteries inside of the brain here, and this would be our Doppler. So again, no images that we are, no images that we're kind of formally used to associating with ultrasound, black and gray and white. But instead, we're going to insonate that part of the vessel, and we're going to grab the speed and the velocity and kind of the profile of the blood flow there. And once it's received back to the machine, it's going to make give us an image like this. So it's going to map out the blood flow velocity. So this would be the cardiac cycle here, and this would be the speed. And this gives us the actual each vessel's blood flow, again, the velocity, the speed at systole and diastole and everything in between. So this would be a normal waveform for a transcranial Doppler. This one is below the baseline just based on the particular artery that it's insonating. So those are some of the techniques we would teach in a more advanced formal training, is how to identify each vessel, knowing the normal velocities, the normal waveform profile. I wanted to talk about just some of the advantages of TCD, some of the advantages of particularly non-imaging TCD. I'm going to actually switch to this slide first and hop back to that one. So TCD actually, it had it was kind of bred out of necessity, where there was a certain situation, and again, we're going to talk about this a little bit more in depth in a minute, where patients needed to have blood flow in their brains checked daily for a number of days in a row. This is still something that's being done. It's actually the most common application of TCD. But the problem is that in order to do that safely, we can't use radiation and dye. So because our brain is encapsulated in a bone, it's not just as simple as waving, something over the arm, or, doing a less invasive test. In order to really see those blood vessels, previously, we'd have to use dye and radiation. So if you put someone through dye and radiation testing once a day for 2 weeks, you would cause a whole lot of other problems. We'd either have kidney disease by the time it's all said and done. So they were limited to not doing what they needed to do every day on these patients to get that data because of those, side effects of more invasive testing. So this was, they actually, let me kind of hop back again. One of the limitations of ultrasound historically, or any kind of ultrasound still, is that ultrasound can't penetrate through bone or air. So, when we're used to, let's say we're going to do an ultrasound on the arm, we just, can freely wave the ultrasound probe over and we get pictures of the tissue. When we're talking about doing an ultrasound on the head, they had to actually develop this very specific technique, TCD, where they could find openings in the skull to shine the Doppler through. So they were able to basically, on these patients that needed to be monitored every day, they could gather information enough to know that there was not a condition, a life-threatening condition developing in these patients. So that ultrasound could be done, and I hope this is true. I know it to be true because it can be done daily. You can have it multiple times a day. We still use it as sparingly as we need to, but I've ultrasounded, I've had a TCD done on myself probably almost every day for the last 2 years. So it can be, you can use it again without the potential harmful side effects. Sorry.
Right. That's one of the nice things about TCD for me compared to TCI, transcranial imaging, is transcranial Doppler. Once we insonate and find the window, we can drop our power down dramatically to be able to observe it for any length of time or be able to find different velocity changes. So we're not using 100% of what's allowed by the FDA. So we're adhering to LARA much better, much more accurately than what an ultrasound is. Because personally, frankly, on myself, I can insonate, get my window at 70%, but if I'm doing a full interrogation, if I need to, I can drop down to 40% power, and we're still not even close to what the FDA is allowing us to have. So we're very, very safe with TCD.
And just kind of talking a little bit more about what you were, the advantages of non-imaging versus imaging would be that we can, in certain patients, ethnicity can be involved. Age is definitely a factor. The bones, we start to lose those large gaps in our skull where we can't actually insonate. So using that very small little almost pencil probe allows us to shine through a lot better than the big, larger brick-like imaging probes. So it's easier to get through those small little holes. And because we're only doing Doppler with the non-imaging, we're not trying to get a picture. We're not, there's other things that we're kind of taking out of the background. It has a very high incidence rate. So it's fast, it's effective. And like you said, we can control the power, the intensity of the beam so that we're only using what we need to. That's especially important with children. And there are some other modalities that we're going to talk a little bit more about too, where it allows us to actually listen to both sides at the same time with a fixed headset. So that allows us to kind of tell exactly what's going on in both sides of the brain at the same time, which can be very helpful with certain examinations. And then we also have software built into the non-imaging TCD that allows us to ask the TCD machine to evaluate a lot of things even further. Also, you can ergonomically superior for sure, because we have a remote usually with the non-imaging TCD, and it's a smaller unit because we're not asking it to do, 500 extra things. It can fit very easily. You can stand kind of near the back of the bed in the ICU. The machine can even be 5 feet away from you, and you could still be performing the exam and controlling the system.
Yeah, you mentioned the size of the probes. 2 of the Doppler probes I have right here. This is our regular diagnostic probe, and we use that at the side of the cranium. And you can see that that is quite small. Another one that's really my personal favorite is the monitoring probe, because you can utilize this to be able to go in the back and slide in on the patient and do your verts and your basal are really nice. It's a nice, comfortable, small probe to be able to use on your hand. You're not using that big ultrasound probe that, as you mentioned, can be quite bulky.
Yeah. And a lot of times, if I'm, when I'm doing any kind of imaging ultrasound, I have to stand on the side of the bed. So sometimes I'm like reaching and moving, where I have, in this situation, I can move the machine instead of having to strain myself.
Right. Right. And with the new systems not having to be plugged in as well, it allows you the freedom of moving from one side to the other of the patient without worrying about unplugging and plugging in. It's just, life is so much better now with the newer Dolphin type TCD system.
I agree. And this is one of my favorite pictures. But this is just an example of what someone having a transcranial Doppler would look like. So we, just kind of maneuver the little probe. We'd be able to see the screen. It's a touch screen, or like, as I mentioned, you can see the remote on top of the desktop there. So the remote actually controls every function that would be needed to actually perform the examination, which comes in handy a lot. Sometimes I need, depending on my patient, sometimes I need 2 hands, one just to hold the patient steady, and then the other to actually perform the exam. So I can be controlling with the remote, holding the patient's head and performing the exam. So multitasking.
Yeah. The nice thing is ergonomics now is so important versus the old days where you were in all these uncomfortable positions. Now with the remote, with the touch screen, everything in the high-low cart, be able to go at the height that you want, it makes life a lot easier for the technologist.
I agree. So I am not, again, we're gonna keep this light today, just a brief overview of a TCD examination. And then I was gonna kind of turn it over to you for a minute to show some of this live in the Dolphin, just to kind of tie it together. So just keeping in mind, we are incubating a very small structure. So the circle of Willis is something that we kind of grow into over life. So it starts off at about a quarter size, and then in adults, it's gets to about the size of a 50-cent piece. So I am just keeping this in mind, the structure here, while I'm scanning, so that I can kind of walk very methodically through each vessel, and I'll know exactly where I'm at as I move through. This shows an example of the different windows. I wish all of the openings in the skull were this large, but this transtemporal approach is where we're going to incinate. I call it the meat and potatoes. So we're going to do the main portion of the circle of Willis from here. Back here, this is the back of the brain. So we're going to be back here doing the vertebral and the arteries, or the back of the neck. So kind of right back here. There's a nice opening there. And then in certain situations, we would actually be listening over the eye. And that's actually one of the good points that you made earlier about being able to turn the power down. We do want to use reduced power when we're over the eye, and we actually have a fail-proof, kind of a system lock when we're in the eye, any of the orbital window that doesn't allow us to increase the power, so we can't, expose the eye to increased power for any reason. And then we have one more window come down here where we would actually get the internal carotid artery, like we were talking about earlier. I like to, so it catches me by surprise every time when the noise. So that was an example of us using the listening. So when we're insonating the vessels, we are actually using our sight as well as our sound. So different places within the circle of Willis sound a little bit different, and a narrowing in a vessel would sound a little bit different. So, I always use the sound. I keep the volume up. And this is just an example of the display on the Dolphin TCD system and all of the different parameters that we would be manipulating during an exam to be able to get a diagnostic exam. Depth is a major component. We actually, like I said, as we walk through each vessel, we do that by adjusting the depth. We would be able to adjust the power if need be, and then we can adjust this other setting called gain that allows us to see a little bit better. And Michael, I think I was going to let you show a few things at this point on the actual Dolphin, so I'm going to let you share.
Would you? I can show you how to acquire a signal really easy on an MCA if you'd like.
Perfect. I'm going to stop sharing to let you share.
All righty. And you should be able to see my screen currently.
Yep.
All righty. So I've just done a standard TCD exam. I'm going to start my probe, and then once I'm finding the waveform, if you could talk, Shannon, because of course I can't talk while I'm doing it. So.
So he's now and he probably knows right where that he can actually feel the opening. He is right now, and I'm actually going to use the circle of Willis that you have here to show. He has the probe here, and we're at 50 millimeters or 5 centimeters deep listening. So we're right about here on the middle cerebral artery. We know we're at the middle cerebral artery just by the sound would be one thing. It has a very distinct sound. We'd be able to associate a normal mean velocity for an adult, which coincides very well with the middle cerebral artery here. And then of course, depth, we know we're about that far in. That plots us right about there. And then this beautiful new innovation called M mode that allows us to kind of differentiate one vessel from the next based on the depth and the color that's displayed. So we're actually seeing Michael's middle cerebral artery, his anterior cerebral artery, and then the contralateral anterior cerebral artery.
So we have the right MCA. Then we'll roll in. This is our MC-ACA. And now we're in my ACA. And now I'm in my contralateral ACA. So the neat thing with this, if we have a patient that's not cooperative, that could be a little bit combative to us, we can go ahead and save waveforms as we go through the vessel. Then I can go ahead and say, okay, now I want to get my MC-ACA. I can move this up. I can then change my label real quick to MC-ACA. I can save some different waveforms here. Or if I just want one waveform, then I can go up to my ACA. Now I want to change my envelope to lower. Save, go a little bit deeper. Save, go a little bit deeper. And then, of course, typically we want to be able to grab our ACA from our left ACA from the left side, but sometimes you don't have a good window. So while I'm here, I'm going to go ahead and grab that contralateral ACA just so I have that in memory, and then I can always get rid of it if I don't want that. So now I'm going to change my label here over to ACA, and now I can go ahead and save this waveform as well, and I can get a couple different depths from that side. Now, of course, typically when we're on the opposite side, we would have had an inverted ACA because it would have been going away from us. I like to keep this going forward just so the doctor, if they see that I have an ACA that's not inverted, that they know, hey, this may be at a different depth, and they would say, oh yeah, this was from the contralateral side.
I can tell you when I'm showing this during trainings, I see a lot of happy faces. I see a lot of light bulbs going off, but I would not have historically before M mode, and especially with M mode that's this vibrant and easy to see, have felt completely comfortable getting the contralateral side in all situations from the right side, or the left side, vice versa. So I think it opens a lot of doors for patients. You could have a patient with bandaging on one side. Like you said, they may not have an adequate window. Sometimes even after procedures where they put in, gone in and put drains or what have you, there's actually sub-Q air that can make it difficult to get from one side.
And I'll turn the screen back over to you, and we can continue on.
All right. Let me hop back to where we were. So kind of and actually that was a perfect lead in to this, just showing, gathering the different depths. As we do, like we're imagining walking through the circle of Willis, we're going to acquire those depths and velocities and waveforms as we go. And then the system actually compiles them into a report such as this. And the physician can see this. There's actually software now that allows the physician to see the exam as it took place. So they can go in, they can remeasure, they can listen again, they can, alter the appearance of the signal if they need to, do what we call post-processing. But the end goal is to hand a physician all of the different pertinent waveforms, and that can change per test so that they can read the report in a reporting software system and be able to have all of that information at a glance. So again, there's different reports, but depending on the different tests, and the system kind of has those all grouped together.
Would you like me to show you a trending report?
Yes.
Oh, Patrick, were you going to say something?
Yeah, Shannon, I see on each of these measurements, we're reporting a peak, a mean, and a PI. Can you explain what those are representing?
Yes, and that is actually a really good question. Now, peak happened to be on at this facility, so I'm going to put that one to the side for just a second. Well, I guess maybe it would be easier to start with that and explain why we don't always report in peak velocities. So if you see a waveform, we'll take this PCA, for example, where this is the peak systolic velocity. So it's the highest velocity obtained in systole. And then the trough, so that's the top of the mountain here, and we have the valley. This would be our end diastole. In, let's say, carotid exams, we're used to reporting the peak and the end. With transcranial Doppler, this mean velocity is kind of where it's at. This tracing line, if you can see it here, if not, I can make it a little larger. We can actually see it on your system.
Yeah, we can see it when I go to the system.
Okay, so it is tracing the highest velocity during the entire cardiac cycle. So it's tracing nearly, I'm not even sure, thousands of points everywhere in systole, everywhere in diastole, and everywhere in between. And that gives us, averaged over the cardiac cycle, the mean velocity. Because in transcranial Doppler, we want to know what's happening just as much in systole as we do in diastole. So all that put together gives us this mean value. But in order for us to know that there's a normal portion of systole and diastole, so we could come up with the same mean, for instance, if we had a very high peak and a very low end, or if we had a waveform like this, we actually observe this pulsatility index. And I do have some slides in a minute that show the pulsatility index. And that just lets us know, kind of summarizing, that there's a normal ratio of flow during systole and diastole. So they're in all intracranial vessels, we want there to be about 30 to 40% of the amount of flow there is in systole, as we want that in diastole, because we want the brain to be constantly perfused. That's important. The kidneys are a similar organ that has the same kind of, low resistance vascular bed. If you want, do you want me to switch over to letting you?
Yeah, I'll share my screen real quick. I have a patient in vasospasm that I can share with you, and you should be able to see my screen again.
Mm-hmm.
This is a patient that is in vasospasm, and of course we haven't talked about the Lindegaard ratio as of yet, but I'm sure that you're planning on talking about the Lindegaard ratio, and that's one of the things we use on a day-to-day basis when we're doing a patient that's in vasospasm. As we can see, this patient is definitely in vasospasm, and you can see our velocities and see our pulsatility index is really changed on this patient. One of the things that I like to show is the trending. Typically in the past, we had to do this manually each day. Either we had to do it on our computer, or I've had a lot of places that are doing it manually, and they were creating these graphs sort of connect the dots day to day. The systems will do this automatically. It doesn't matter. Hey, you can have 2, 3, 4 systems. It doesn't matter which system you grab for the day, because they do hold that information for all patients day to day for you. This is a really interesting case because in the past, we weren't typically tracking the pulsatility index on day-to-day basis. We were typically looking at the mean. And we can see on this patient, for the first 5 tests that we did on the patient, the mean staying pretty stable and it's pretty normal. But look at this pulsatility index taking off on us. This gave us a heads up that this is a patient that is going to be trending with vasospasm, typically that we would see in the MCA, and gives the doctor a heads up ahead of time so that we can actually start treating them much easier. And this is so important to be able to find patients quicker instead of waiting for that vasospasm to kick in. Is that, to you, saving a lot of lives, Shannon, be able to do this?
Absolutely. It's actually one of the first modalities that I learned, and trending was not as easy on the system that we were using. It didn't automatically derive the highest mean from each day from each vessel. So in order to use the trending, we actually had to shave our exams down. So this is a beautiful thing for me. And it really, to me, the trending, not only does it just visually kind of make it easier to see, so that you notice those overall, peaks and valleys or consistence, if we're going up and kind of plateauing. It also can be a way for, if you have a large staff that's going up and performing the exams, and you're consistently seeing on Wednesday that we're having down spikes, and then we're back up on Thursday, who's working on Wednesday? But it to me, the trending is one of the most valuable features to be able to see. And I think it's important to kind of talk about, vasospasm in general and, why we have to do this for so many days in a row, and why we would want to know what the values are the day before, for instance, compared to the value today. And, I know vasospasm patients, it's a unfortunate side effects sometimes from patients that have had subarachnoid hemorrhages. And as stroke centers move more towards becoming certified stroke centers, TCD is actually something that we will see more and more because it's required in their regimen. So
Right.
if you were in a town and you had one hospital that had transcranial Doppler and the other didn't, you would definitely want to land at the hospital if you've had a subarachnoid hemorrhage where they're using transcranial Doppler.
Even if it's not, if it's not subarachnoid hemorrhage, even patients with stroke can benefit immensely by going to a facility with TCD. It gives you so much more of a heads up of what's going on intracranially on that patient. Are they having emboli, or is this something else? Is the emboli coming from the heart, or is it coming from, intracranially? So it's really nice.
Well, and in real time. So
Right.
some of the applications that we're going to talk about, you wouldn't necessarily have seen the event happen if you were just doing, looking at a CT. Even sometimes it shows the direction of blood flow, so it can show us if something's reversing. So it actually has even additional benefits beyond CT, where we're looking at all of that happening in real time, making recordings. There's sound involved, like we talked about. I have a couple slides here that that specifically talk about subarachnoid hemorrhage. And we'll kind of keep it light, but now that we've looked at it on the system, so subarachnoid hemorrhage, just giving you a brief overview, we can have a subarachnoid hemorrhage from any number of causes. The most common cause is definitely going to be an aneurysm. I think there's an estimated 30,000 aneurysm ruptures in the United States a year. That number probably is on the rise, where it's, something that's oftentimes familial. Uncontrolled blood pressure, hypertension can be a cause. So we get this rupture, and the blood clot can end up residing, depending on where the rupture is, a lot of circumstances involved, but it can end up residing in any number of places in the brain. TCD can be useful no matter kind of where it ends up. But specifically, if the hemorrhage is down here, the blood clot, it'll, in the subarachnoid space, which is the space that surrounds the brain, it can overlie the vessels in the circle of Willis. So if you think about, getting a bruise on the first day, you have the bruise, that would be the date that we have the aneurysm. The bruise is purple, angry purple. And then over the course of 4 or 5 days, we notice that the bruise starts to change color. So there's a chemical process taking place within the body that's breaking those blood vessels, the residual blood cells down. And unfortunately for patients with subarachnoid hemorrhage, if they survive the initial event, so they've come to the hospital, they've gotten the initial treatment, they survive this big brain bleed, they're looking like they're in the clear, there is a secondary thing that can occur to these patients as a result of that blood clot breaking down, and that's called vasospasm. So basically, this is a very powerful image. I like to show this. As the blood clot starts to break down, the chemical byproduct can actually cause a normal vessel within the circle of Willis, or the head, to shrink down this many times. So if we shrink a vessel this much, we effectively can put a patient, or we aren't shrinking it, but if that is the result, if we have that much of a spasm, the patient can actually have an ischemic stroke, 5, 6, 7, 8, 9, 10 days after the initial bleed because they can't get enough flow through that narrowing. So TCD, and this is actually what kind of spawned TCD as a necessity, we can analyze that blood flow on that same patient day after day after day, and we can compare using the trending that you were mentioning, that we have, let's say our mean flow velocity at start was 50, and then day 3 it's 60, day 4 it might be 100, and then all of a sudden we're spiking. Then we know based on those mathematical principles that the vessel has reduced by that much of a size. So now with modern medicine, after we do surveillance for that every day, we can actually go in and intervene and stop the vessel from spasming and save the patient's life. This slide right here, this is just the trending we already kind of talked about, but this would just be an example of looking at it day after day. And vasospasm usually occurs about day 4 to day 7. So even if everything's totally normal for 5 days, we'll still keep doing a daily routine TCD. And I thought I had an example of a report in there. I might circle back to that, but you actually were able to see it a few minutes ago when Michael had the system pulled up, that those velocities were getting extremely high. And then, as you mentioned, the Lindegard ratio, what we would do is we'd make a daily calculation of the flow that's outside of the brain and compare it to the flow inside. And as that vessel narrows, this will stay the same and this will start to increase. So think of it as like pinching a hose. When you pinch a hose and create a narrowing in the hose, or the velocity or the speed of the water shoots out. So we're basically, it's a matter of physics. So if this goes up and this stays the same, then it's proof that we're experiencing vasospasm.
Right. So what's happening is your velocities are going up, but less flow is actually getting into the cranium. So that's what's causing a major deficit for the patient. And of course, it can eventually lead to brain death.
Yeah, and you scan these patients, you really become emotionally attached to them after 2 weeks. So you're going in, you're fighting hard to do a very diagnostic study for this patient, on all possible fronts, so that if the need be, that they can have the intervention that they need. And that's actually, when I first got involved in doing transcranial Doppler, that's what was so fulfilling about it for me. You go down, most facilities have an immediate reporting process. So the doctors, you go up early in the morning, you do the test, and then when they do their rounds later that day or in the morning, they have all of this at a glance for them to look at the values and make a decision for that patient for the day. Do they need medications adjusted? Do they need treatment? So on and so forth.
It's interesting you mentioned that relationship you get with that patient, because you are seeing that patient for 15 days. And that's one of the things that I've noticed with Patrick. Patrick makes it a mission to educate the doctors on the reason we need to be doing this, not only for vasospasm or TBI, traumatic brain injury, but also all applications. And it's a life-saving diagnostic procedure that we're doing, and there's little to no risk. It's just amazing.
Yeah.
One of the things that I've found over the years that I've been doing TCD is that the reasons for TCD not to be done are almost exclusively a lack of technologists. It's not a lack of indications. It's not a lack of benefit to the patient, because as mentioned earlier, if facilities aren't doing TCD to the level that they should be, that patient is probably going into the CT or the MRI or having an angio far more frequently than they should be. And so it's a benefit to everybody to move towards TCD and increase the number of folks that are able to perform these tests.
Agree
Agree.
100%, Patrick. 100%.
And a lot of facilities now are moving towards streamlining, having appropriate, training, getting everybody's staff certified and so on and so forth. So there's a lot of avenues opening up to do that. I want to make sure we have enough time to talk about everything. So I'll kind of talk about these a little lightly. There's definitely one thing at the end of the presentation that I want to talk a little more heavily about, but just as we can screen for increases in velocity, like we were talking about, we can use that pulsatility index to actually determine if intracranial pressures are getting dangerously high. And I feel like this is something that's probably going to be on the rise, an application of TCD a lot in our fast and furious nation that we're in. So we call TBI, traumatic brain injury. What we can actually see, and this is just giving kind of an overview of how prevalent that is becoming in our society. We have a brain injury, and because we have a fixed space, so our skull can't readily expand or contract, when we introduce something like a clot, or we introduce edema or anything, increased cerebral spinal fluid, the first thing that's going to be affected is going to be the blood flow, because that's the most pliable thing within inside the brain. So we're adding something in, increasing the pressure. So, it's like inflating a balloon that's already so full, but is never going to pop. So the pressure actually pushes back. So this pressure starts to exceed the pressures in the heart. We all already discussed that we always want the brain to be perfused in systole and diastole. So we'd start to see something like this occur, where we have a normal pressure, the pressure in the brain is lower than the pressure in the heart during diastole. Now the pressure in the brain is starting to exceed or match the pressure in the heart. And now it's exceeding it. So we're no longer allowing net forward flow to the brain during diastole. And this would be an example of an extreme situation where we're actually forcing blood flow backwards. So the heart, the brain, whichever one has the higher pressure is going to win. And that's actually, we can monitor this daily, where if we were to see this, number one, we can provide intervention. They can put in ventricular drains, they can do craniotomy, or simply increase the pressure in the heart with medications, so we can maintain this. And I've actually firsthand saved a patient's life. I was actually doing vasospasm surveillance on her, but I noticed her like you had on the trending, her pulsatility index going up, and I called a stat, and they were able to determine that that was the case, and go down and provide intervention in that way too. And this would be an example. It's unfortunate, but it is another application of transcranial Doppler, where we can be asked to go up and do, it's a limited exam with certain evaluation points to make sure that we're not seeing signals like this that would be indicative of cerebral circulatory arrest. And then there would be confirmatory, obviously we would never base this on one exam or just two, but this would actually help confirm a situation like that. So this is one application that's that's near and dear to my heart. I feel like it's one of the most globally applied applications of transcranial Doppler, and obviously when we're working with children, near and dear to everyone's heart. Sickle cell children, I would say sickle cell anemia in general is becoming a global, almost pandemic in certain areas. So we're specifically in the United States, especially in certain regions of the United States, we see a lot of children with sickle cell, and you'll see families that have 2 or 3 children affected by it. And children especially cannot be exposed to radiation and die. So kind of getting back to the same thing where we were talking about with the vasospasm exams, where we can do a transcranial Doppler on a child multiple times. We can, do it several times a year to monitor their blood flow, and we can do it safely. So a sickle cell, just very simply, simple description, it is a genetic disorder that affects the shape of red blood cells. And instead of having like round discs that bounce readily off of each other, we get these sickle shaped cells, say that 10 times fast, where they hook together. So they're stickier and they hook together and they cause these clumps. So it's unfortunate that that clumping occurs in the smallest vessels throughout the body. They can suffer from pain crises, in the limbs where the vessels are really small, but especially in the circle of Willis in children, because we talked about it being the size of a quarter. So these can easily tangle up and cause narrowings and kind of web-like blockages. It affects the MCA and the distal ICA a lot. And about 11% of children can suffer from a stroke as a result of this. So we're able to take the children's velocities, on one visit and then compare them on a subsequent visit. And there was a big research study. There's actually been multiple, but the one most notable is called the STOP protocol, or the STOP study, where they determined certain thresholds of velocities that are directly associated with the children having strokes. So they find if that we call it an abnormal velocity, or if that kind of like alert velocity comes up, then they will move to putting the children through either transfusions or on a medication protocol. So usually these children come in one day, they have the transcranial Doppler, and then they go and see their hematologist in the same day. So again, it's another example of the physician acting directly on the results of the test and possibly saving a child from having a stroke. So, and this is, again, it's a worldwide application. So all, it's pretty standard all over the world that this is the best way to help do the surveillance on the children. I love this picture. This is
that's showing the Dolphin XF, and as it shows, it can be used on pediatric or adult. It's a great technology, makes TCD much easier in a monitoring situation, not for full diagnostic exams, because we can't do posterior very well, and you have to do ophthalmic, but it's fantastic for doing MCA, ACA monitoring.
And did you want to show a video of the head frame application?
Sure, if you don't mind, I would love to show you a quick TCD with the headset. That'd be great.
Okay.
Can you see my screen?
Yep.
Great. Is what we're doing here is just putting the headset on the patient. As you can see, it goes back below the onion. Then you're going to put the top part right above the eyebrow. Just snug it down. It's not tight. Then you move both probes over the temporal window. Quite simple. It is easier if you use the TCD probe ahead of time and find the temporal window. However, if you don't do that, you can't. It does have a signal generator where it'll tell you if it's going in the window or not by turning green when it's in the window and yellow when it's not. So right now he's just explaining that he's putting it over the temporal window. Once we get it over the temporal window, we snug it up. Now we're going to put some gel in. And it's a standard gel, nothing fancy about it. It's sucked up into a 10 cc syringe. And now we're just going to hit the auto find. And we have quick find and fine tune, but the quick find will find it usually in about 20 seconds. If it doesn't find it, then it'll tell you to move it forward or back. The blue is flow away from the probe. The red is flow towards the probe. The higher concentration signal would be the more vibrant color. And now the system's going to get set up to go to the forward flow. So it locks in on the MCA bilaterally. And you can see on the system that he can go to a different one. This one right here, you can see is saying it's towards the ear. So we can go to a different vessel group if we wish by clicking on it. Now it's going to go back towards the PCA, and we can see indeed that is a PCA waveform. And then if we wish, we can go back to the main flow, back towards the positive flow. And another thing we can do if we want really good waveform is hit a fine tune. By clicking on fine tune, it's going to do a very tight pattern over that area that we selected to scan. And it's moving very, very minutely now on its own, the robot is. And then it will go to the highest velocity and lock in for us. So you can see that that's a really nice, quick waveform.
That was also a good show of how the machine is calculating the pulsatility index and the mean flow velocity in real time. So it's calculating on a 4-beat average. So it's not a static, there's different things that could make it elevate and lower actually within a few seconds of time.
That's why it's very nice, because it's so real live, it's real time versus a lot of the stuff we do in the neuro lab is after the fact, where this is instantaneous.
If we have time, we'll make you do a breath holding test. I tried to do that at my house in Colorado, and holding my breath for 30 seconds at 9,000 feet is a lot harder than it is at sea level. So we just wanted to show a few of the applications that are kind of blanketed under the monitoring. We tend to kind of blanket monitoring exams as exams that will use the head frame to listen bilaterally, or we're listening over an extended period of time, or there's a special software within the system that we're asking it to do something more than just listening to the mean flow velocity at certain times. We have a kind of a subgroup of exams we call microemboli detection. So just simply put, we would be listening to a certain vessel in the circle of Willis. That can be either the anterior or the posterior circulation, depending on where we think the issue is coming from. It's pretty standard to listen to the bilateral MCAs, and we would actually be listening for emboli or pieces of debris traveling through the MCAs. So that would involve putting the fixed head frame on, or the Dolphin XF, for maybe 30 minutes or so, and letting Mother Nature, do her thing, and listening to see if we hear something that's not supposed to be here, evident here. A very specific subgroup of that would be the PFO studies, where we're actually listening for debris that's directly coming across a PFO or a residual flap in the heart. So coming from the venous side to the arterial side. Monitoring during surgery is something that's definitely becoming a lot more prevalent. We would you want to have surgery somewhere where they're listening to see if they're accidentally showering emboli into your Willis, or they're not? And that could be carotid surgeries. I actually have seen it used during pediatric heart surgeries, where they're fixing transpositions, or basically things that are attached incorrectly at birth with the venous and the arterial side. So they'll actually inject some saline and make sure that it stays in the venous side of the heart, and that means they've corrected the issue. And then a subgroup of studies called vasomotor reactivity exams. So that is basically going to test to make sure that we have proper expansion and contraction of the vessels in the brain, because we do want that to be something that's taking place without hindrance.
Would you like me to show you some hits on the system?
Yeah.
Very good. I'll share my screen. And I have the PFO protocol up, but monitoring bilaterally is the same. I have an algorithm right now on so that it will actually have some hits so we can all see something. So right now we're going to just monitor both sides on the MCA. While we're doing this, when we're doing a PFO exam, we'll have the patient do a Valsalva on the patient. So when the patient holds their breath and bears down, those are all actually hits going through here. And if a patient did this on just a Valsalva, then we really wouldn't do the injection on the patient. And what I just switched to is power M mode. That allows us to see the hits easier. Now is what I'm going to do is act like we're going to do session 2. We're going to do an injection this time on the patient, and then we're going to have the patient do a Valsalva as well. These are just a microbubble injection. So I'll do the injection. Now we'll do the Valsalva. And you can see here very easily, when we look at the screen, all of these bright streaks, those are all hits, high intensity transient signals, which are typically embolic events. Over here on the left-hand side of this page makes it really easy for us to see if it's coming from the heart, like a PFO, or coming from the lung. Typically, we want our first hits to come in under 15 seconds to be a PFO. If it's greater than 20 seconds, we're assuming that it's probably coming from the lung. Am I correct in that assumption, Shannon?
You're correct.
And the benefit of that now is what we're seeing is because a lot of people that had COVID, they had damage to their lungs. And so we're getting a lot more patients that we're actually seeing hits coming in that 20 or greater. And that's from that alveoli having those damages, being damaged. The system automatically, as you can see, counts your hits very accurately. The system also, the Dolphin, also does a hits analysis in what it's looking at when it's looking at a hit. It's looking first to see about the decibel range above the background noise. Is it above the background noise, which it is? In this case, you can see that hit. Is it traveling at the same speed within the blood, or is it traveling sort of chaotic? And we can see here that they're very in sync with each other, the blood and the hit. And then the energy has a frequency that's very concentric. It's not all chaotic. So it's definitely a 3-point analyzation would tell us that's a hit. And it does that for every hit or artifact that's coming through. And from there, I'll turn it back over to you, Shannon.
All right. Sorry, every time I go back to sharing, it takes me out of the slide presentation. So, well, I think it's important just to, because this is such a broad topic, microemboli detection, just kind of talk about some of the scenarios where it can be applicable. Michael, I know you recently had a scenario where, it was near and dear to your heart with a family member where this technology really could have kind of expedited some diagnostics. But one common reason to do the microemboli testing would be if we feel we have a patient that came in with what we call a cryptogenic stroke. So we're not exactly sure, or a TIA, where it's coming from necessarily yet, but we want to prove that indeed something is showering. And then if we did find that it is, using the technology that you just showed, then we would do a full system workup to figure out where it's coming from. And I have a couple of examples of places or things that could lead to embolic showers. Or if we have a patient, we kind of want a preventative medicine. So we have a patient with a carotid plaque, like you can see actually here. This is an imaging picture from a carotid where we've kind of hollowed out this plaque. If I saw this when I was doing a carotid exam, I would be very concerned. And I would certainly, this patient may not be at the level here based on the narrowing where they would be surgical candidates. But if we find that they have this plaque that's being scooped out and that plaque is going, upwards, then that little tiny, this plaque that doesn't seem as small, this hole right here, if that plaque lodges in the vessels in your circle of Willis that are about the size of a strand of spaghetti, that is not a good thing. So we would be able to do the embolic screening to see if it is, and then of course they would go to surgery. Another would be cardiac in nature, and we can see this in patients that don't have a very good squeeze in their heart, and they tend to develop little microclots in the heart. Patients with atrial fibrillation can develop clots and little crevices, and that's very much so becoming more prevalent, especially as patients start to live longer and longer. We kind of wear out the ticker a little bit, where it starts to misfire a little, and it causes swirling at certain parts of the heart. So that can be a stroke risk for sure. Patients with artificial heart valves, patients with numerous types of conditions. So we would place the head frame on and listen for about 30 minutes and use the software that you just showed to detect those little emboli showering. And just kind of tying it back over to what we were talking about with the examination that you were showing on the screen there, a PFO. This would be a situation, and this, I just want to get to the facts and numbers here because it's pretty staggering. We have about 100,000 cryptogenic strokes per year, and this is talking in the US. They've attributed, and I think it's an underestimation, probably about 40% of those to being PFOs. So a PFO is a little residual flap between the right and the left side of the heart, where very small flap may not be a problem. If the flap is larger, or if the patient has maybe a DVT or a small clot in the right or the venous side, so maybe a small clot in the leg, patient coughs, flap opens, clot goes to the left side, clot either goes up or down. I'd rather it go down into my toe personally, but if it goes up, again, that little tiny clot can get lodged in those vessels in the circle of Willis and be detrimental. So we see this being performed more in younger patients, younger and younger. Patient comes in with stroke or stroke-like symptoms, they're 40. There's not a whole lot of other things that can be causing it. So you kind of start narrowing it down by the decision here. Migraines. Again, I've seen multiple patients with migraines be helped with by this. And I love this, just telling this story. One of the trainings I did for you, Michael, at up northern Michigan, we did PFO exams on 9 staff members, and including myself. 4 of them were positive, and 2 of them were largely positive. And I have a PFO, by the way.
And that's just amazing to me that we aren't testing more for PFO, because as the numbers come out, I remember in the 90s and 2000s when we first started doing PFOs with TCD, everybody was saying, oh, it's 4%, 5%. Now we know it's at least 25% and even higher in some sets, in some different ethnicities. That's crazy that we're not diagnosing those, because people that have a PFO, if you have a clotting disorder, you're at high risk for having a stroke. You need to know if you have a PFO, because your body changes as you get older, and a lot of people do have clotting disorders as they get older.
Well, too, if you have like a PFO, just from a cardiac standpoint, the longer your PFO is shunting blood back and forth, the bigger it's going to get, the more it's going to shunt, and it becomes even an increased risk. What may have been very benign at one point it becomes an increased risk the longer you live. And I remember very specifically a patient that came into the ultrasound lab. She was about 35, and they ordered an echo bubble study, thankfully. And the tech did I would say, you know, maybe she had some tough windows, maybe the tech didn't put as much effort and it was considered to be negative. And we pulled her back out of the wheelchair and went, you know, through and asked if we could order this examination, and actually it was very easy to see that it was positive by TCD. So she ended up having a PFO closure the next day. So it's you know, number one, it's under ordered, and number two, it's often ordered through the cardiac department where the sensitivity it's just not the same at all.
I know that's what I notice is on a regular basis, that they're doing it in via echo or TEE, and the accuracy on TEE and echo are 70%, 72%, around there for sensitivity. And with TCD, we're in the high 90s. And it's so much easier on the patient. When I was at University of Washington, the first time I sat in on a PFO, the patient came in, she had already had a PFO exam at another location at that facility for doing it with TE. When we're hooking her up and testing her for PFO, she says, this isn't going to be as bad as the last exam, was it? And I asked her, well, what did you have last? And she said, I had a TE and it was awful. And I said, oh, no. So we did the exam. It was positive on the patient. And when we were done, she says, now, can you tell me something? Is this as accurate as the study that I had, that TEE? And I wanted to say it's more accurate, but I didn't. I said, yeah. And she says, well, can you tell me why the heck, she used other language, but why the heck they did that other exam first before they did it with TCD? And I had no explanation for her, because why not do the more accurate exam first? And then if you need to do other testing, this is so easy and so accurate. It just doesn't make sense to test for PFO any other way.
Well, and you can't do a Valsalva while you're sedated.
Yeah.
I have a quick, it's like a 1-minute video of a PFO exam being done, shared with permission from the individual. It's not a patient, it was a staff member. And then I think Patrick, we wanted to wrap up with having you give some information about the credentialing.
We are doing our third injection, following the same
This is pretty profound
mixture, the drop of blood. We're going to agitate for at least 10 seconds, and coordinate when we're ready to inject.
Okay, 5, 4, 3, 2, 1. Okay, injecting. Okay.
We have our patient do the Valsalva. You can see the drop in the mean flow velocity. For 45 seconds.
Shannon, that would be grade 5, correct? Or is that a grade 4?
She's at the upper end of a grade 4.
Grade 4, okay.
And that was kind of the end of the PowerPoint. And I just, I think that's a very profound, you know, we found she was having migraines. She wanted to have the test done, and that's what we found.
Patrick, you know, we all are very happy about the new accreditation that all of the medical providers are eligible to take and do. Can you shed a little light on that and share the screen on this? You're still muted, Patrick. Patrick, you're muted. Patrick?
Can you see my screen now?
Yep.
Now we can see your screen and you're unmuted. There you go.
Excellent, thank you. The neurovascular specialist credential has been around for a couple of years now, but it's only recently been adopted by some national accreditation agencies. So it is a path now that is independent of the RVT. So folks with EEG or neuromonitoring backgrounds, as you can see here, now have a pathway to become certified to perform TCD exams. In the past, I have a lot of customers, including facilities like Stanford and Cedars-Sinai, who have neurovascular technologists that are performing TCDs. They're not RVTs. And although some of them have gone through and got taken the examination and got the NVS, it wasn't a requirement. Whereas I believe in the next 3 to 5 years, this will be used to determine or to help with quality control in those environments. And so I just wanted to pass on that to everybody involved, that there is now a pathway for you to become certified as a neurovascular specialist. And if anyone wants further information about how to go about this, they're welcome to reach out to me, reach out to Shannon, reach out to Michael, and we can put you in chart or in touch with folks that can kind of hold your hand along the way and assist you with the performance of studies and education that'll get you to that certification.
Yeah, this is a great opportunity for facilities. One of the problems or barriers before for certification is you had to actually become a full sonographer. And, you know, in order to be truly certified to do it. And now this is a nice shorter case for you to be able to become a good TCD neurotechnologist. It's fantastic. And it's much easier, but much more diagnostic for people, because I know a lot of sonographers, my own daughter, she had maybe a week worth of TCD and TCI, and that was it, and really not any specialization. So this really helps people that are doing, you know, cranial care. I love it.
And one of the things that Shannon brought up earlier was that you can get credentialed as an NVS intracranial without having to do the carotid aspect of it as well.
Yep. And we can definitely, as you mentioned, to reach out to us, because we at Sky Vascular can provide the CMEs and study material, if you know, recommendations, and then also help with getting the scans under your belt. So if you're already doing the TCDs, that can be easier, you know, if you're doing them within your facility. But if you need, you know, if you're just kind of getting started with it and need those TCD scans, we can help arrange for that to take place too.
Yeah, with Sky Vascular, anyone that's looking for education or wants to get certified or just wants to know TCD inside and out, Sky Vascular is a great resource for you. They have on-site as well as web education for you. And then I would also like to give a shameless plug for the poster you see over my left shoulder. We give those out for free. All you need to do is contact Patrick or myself or Shannon. Any of us can have it sent to you. It's a great poster and educational piece for your patients as well as your staff. Great. Well, we'd like to thank everybody. Any questions or anything? I mean, Patrick or Shannon, would you like to say anything before we close?
No, I just really appreciate the opportunity. Thank you.
Yeah, I just wanted to say, give some kudos to the folks that decided to include TCD in this this educational series that is being presented. TCD is growing. There's a need for more TCD, and it's nice that that's being recognized across the clinical spectrum. So I appreciate it.
Yep, I agree 100%. Thank you very much, Patrick, Shannon, and thank you, California Neurodiagnostic Society, for inviting us in. And we're here for you anytime you need us. Have a great day.
Bye, guys.
Awesome. Bye.
Bye-bye.